Good afternoon, everyone. I'm Christy Koenig, and I serve as the EMS Medical Director for the County of San Diego. Thank you so much for joining us for today's session entitled The Golden Hour in TXA as part of the Base Station Physicians Committee monthly evidence-based medicine lecture series. Today, we're pleased to welcome two renowned expert speakers. Dr. Dave Duncan is currently assisting us with EMS in the County of San Diego. He previously served as the director of the State of California EMS Authority, among many other high-level positions. During his 20-year tenure as CalSTAR and REACH Air Ambulance Medical Director, pre-hospital critical trauma represented the majority of cases they managed. As AMSA director, Dr. Duncan developed and implemented a statewide unified scope of practice for flight medics. In fact, he was among the very first in our entire country to initiate pre-hospital TXA to critical trauma patients across an entire state. And if that's not enough expertise to share, we will then hear from a very special guest, Dr. Ian Roberts, professor of epidemiology at the London School of Hygiene and Tropical Medicine, is zooming in from across the pond to join us today. I believe it's 8 in the evening in England now. Professor Roberts is internationally recognized for his lead roles in several large TXA studies, including the CRASH trials and the Women trial. Following the two presentations, we will have time for a question and answer session. I believe you will find this session both educational and entertaining. Welcome, everyone, and please enjoy and learn from this session. Dr. Duncan, over to you.
Thanks so much, Dr. Kagan. I'll share my screen here and be sure you see that okay. Is that coming into view?
Yes, sir. Looks good. Your face, though.
Let's just grab that. Okay, there we go. Do you see the slides, Dr. K?
Looks good.
Thank you. And I'm guessing you're hearing me okay. I'm going to dive right in the interest of time. Thank you for that spectacular introduction. I'm Dave Duncan. I'm joined today by Dr. Roberts, as so eloquently introduced by Dr. K. Yes, he's joining us 8 o'clock his time over in London. Hopefully he's drinking something maybe more exciting than this. We'll catch him on that in a minute. We'd like to talk to you today about the strong evidence surrounding a couple of very important trauma interventions. And I'd like to personally thank him for spending his evening with us. So thank you, Dr. Roberts. I'm going to dive into a couple things. We're going to briefly touch on a couple of trauma stats because those numbers remain impressive. But more importantly, we're going to focus on the evidence surrounding what I see as the top two most important pre-hospital trauma interventions. First is the timely delivery of care, including timely transport. Many refer to this as the right care at the right time. And then secondarily, an incredibly important intervention for massive hemorrhage that I don't think we're utilizing as often as we should in California and the US, and that being TXA, of course, more to come there. Everybody's favorite, just a quick, brief rendition on trauma statistics and demographics. There's some interesting history here. The approach to trauma was really brought front and center by a 1966 white paper published by NHTSA, known as the Accidental Death and Disability, the Neglected Disease of Modern Society paper. Christy's going to throw that in the chat for us. It's a great short read, and the amazing part to me is that it really mirrors where we are now and what we do, set the stage for trauma centers, trauma systems, and even air ambulance. So it's interesting to see where our history began. As far as stats go, we continue to lose large numbers of trauma patients annually, pushing 15,000 in California. That's 30 to 40 a day. It ranks as the #1 cause of death for the ages from 1 to 46. I like to lump trauma into what I'm going to call a 50-50 category. There's a number of sort of 50-50s that I'm going to share with you, and I do that because I think it's easier to remember. So for me, trauma is responsible for 50% of the deaths under the age of 50. But maybe more importantly, it's responsible for stealing more years of life than any other disease, and in fact, accounts for more life years lost than both cancer and heart disease combined. Why is that? Because the average trauma death occurs at about 38 years of age, so you lose about 40 years of life with every trauma death on average. I'm going to dive kind of right into the golden hour here. This is so interesting to me. The validity of the golden hour has sort of fallen into question over the last 10 or 15 or so years. There have been a number of articles and studies to try and maybe debunk, the golden hour and its applicability to what we do. Dr. R. Adams Cowley is largely attributed with, hopefully that's not me, largely attributed with the golden hour term after he published a comment in a 75 article where he stated, the first hour after injury will largely determine a critically injured person's chances for survival. In sticking with the evidence-based medicine theme of the day, I'm going to point out that coming from expert physician opinion was level 4 evidence at the time, or maybe level 5 evidence at the time. But that said, that was the top of the food chain, and that evidence has since been supported by many other studies and has risen to the top of the evidence-based pyramid. And I'm going to show you some of those studies that I think help validate what we see with his statement. A couple of pieces that we need to prove or bring to bear as truths before I move forward and before we can kind of dive in and believe this as fact include that the timely delivery of care does save lives and make a difference. And then maybe secondarily, what about this 1 hour mark? Does the 1 hour mark have significance and validity? And I'm going to show you, I think, as definitively as possible that it indeed does carry that validity. So first and foremost, I think if we're going to understand the golden hour, we have to understand when our trauma patients die. This is an incredibly important piece if we're going to intervene, because if we don't intervene before death, it's probably not going to be effective. Just saying. That said, here's another of my 50-50 categories, and that is in trauma, 50% of the deaths, 50% of the mortality occurs in this DOA group. So dead on scene, don't get transported. That's a very large chunk of trauma mortality sitting here and demonstrated by a very nice meta-analysis here of numerous studies, continues to be demonstrated by continued studies. This reminds us also for another day that if we push the timeline further to the left before the accident, maybe there's more work to be done in the trauma prevention arena here. So moving out of the scene, maybe into the transport arena, we've lost 50% of our trauma patients. What about the remainder of the folks that are currently alive but are destined for death? We have 50% of them en route to a hospital. It ends up that half of those will die in the first hour to hour and a half. So pretty amazing statistics centered around this first hour of time. In our trauma patients, we've lost 50% of them immediately. There's another 50% destined for death, and half of those are going to die in the first hour to hour and a half. That said, we can now transition into a curve that maybe many of us have seen. That includes, somebody's mic's open, by the way. That includes what started out and was described as the trimodal distribution of trauma deaths. Trauma deaths were distributed into, and rightly so, an immediate group, an early group, which they like to consider, occurring largely maybe in and around that first hour of time, and then a later group. The part of this that's an untruth is that this really ends up not being trimodal. There aren't 3 bumps associated with this curve. There are, though, demonstrated statistics that we do lose within this first hour, within this golden hour, we do lose 75 or 80% overall of our trauma patients. But the curve looks more like this. And this is one example of validating the shape of this curve. This is the crash to sort of time of death curve that Dr. Roberts published in Crash 2. It also breaks apart those that died from neurologic versus hemorrhagic injury. Quick note, you'll see on day 1, higher majority are dying from hemorrhage than neurologic, and then that transitions to the other side of the fence beyond, I'll call it day 0. But the shape of the curve really is kind of an exponential decay curve downward, and looks probably more like this. If we consider the golden hour, we have the most deaths immediately, but as minutes pass along, we have fewer and fewer deaths along the way. So what about this golden hour? It ends up the golden hour maybe is an arbitrary line, but it also ends up being a perfectly drawn arbitrary line, because 60 minutes is kind of a perfect spot to set the stage for goals, objectives, and interventions for our trauma patients. We again have, 75% of our deaths happening underneath this mortality curve over here. We need to intervene before. You can imagine if we set the stage at, say, a golden 30 minutes, we'd have an awful lot of unsuccessful interventions, and we'd all be taking more antidepressants maybe. So I like this 60-minute caveat, and we'll show a little more why that's pertinent. More along the 50-50 category for trauma. We've talked about, this 50% die on scene. Well, it ends up, as you're getting transported, also if you're destined for death, and we saw this briefly in Ian's mortality curve, about 50% of these are going to die from hemorrhage bleeding. That's our interested party of the day. About 50% of these folks are going to die from CNS injury. That's again, maybe for another day. But before I dive into summarizing a few of these studies, I want to briefly touch on evidence-based medicine, again, being the theme of the day. There are a number of models for evidence-based medicine. Most of them continue or consider levels of evidence from 1 to 4, 1 to 5, or 1 to 6. They all tend to have one thing in common, and that is that the top couple of levels center around prospective randomized control studies or meta-analyses, and that's where we're going to try and center our attention today. I'll point out, and I used to point this out to my flight nurses, and I was reminded of this constantly, that physician opinion is way down here at level 5. So Dr. Duncan, please remember when you're imparting your opinion rather than, than what's fact, and it's hard for us to do that. Here, unfortunately, is what frequently happens, right? When we try and institute evidence-based medicine, particularly when it flies in the face of what we do every day. But here's the important takeaway for me, and that is, and especially after spending my couple of years at EMSA and COVID, we have to battle hard to make sure that the public health level decisions we make are based on the best evidence that we have at hand. And when we can avoid it, they're not based on simply opinion. So let's move in to talk about some of these studies. Not everything lends itself to a randomized prospective study. I love this study published by The Lancet. This study demonstrated that indeed there's no good prospective proof that parachutes are helpful. And it just goes to show that, we don't have a randomized odd days parachute, even days no parachute study to validate yet we know parachutes are helpful. And, obviously all in fun, but made a great point. And we can transition this, I think, to the golden hour. So very much like parachutes, the golden hour is tough to prove prospectively. And we can't really set up a prospective study where on even days we're delivering patients in less than 1 hour, and on odd days we're delivering them in greater than 1 hour. Telling our patients, just hang on a minute. I can take you in another 15 minutes. I know you're bleeding, but this is the way it is. So that said, we have to look through the literature to find good evidence that gives us maybe prospective or the best evidence available, in spite of not being able to necessarily randomize this data. and I'm going to touch on a few of these studies. The first, I like this study because it's the first that set the stage to demonstrate or to try and demonstrate that the golden hour may not be a thing. Many folks jumped on the bandwagon of this study. I think many folks didn't really read this study in detail, but many walked away with just reading the conclusion that said in this sample, there was no association between EMS intervals and mortality among injured patients with physiologic abnormality in the field. And they left out the line that should follow that, which I'm going to show you here in just a brief second. A couple of problems with the study, and these are significant problems, included first this caveat, which was they started with attempted enrollment of 9,200 patients, and after kind of screening criteria, all these are steps in screening, they ended up enrolling about 3,600 or 1/3 of those possible enrollees. So, who knows exactly what happened in this enrollment process. It left us with, a lot of missed patients. Secondarily, they're comparing what happens to patients delivered before 1 hour to those delivered after 1 hour. But when we look at the data set, the vast majority of the patients included in this study were enrolled in less than an hour, less than 10%, closer to 5% of the patients enrolled were those extending and delivered beyond 1 hour. So it makes the comparative group pretty darn thin. Maybe lastly, and this is the takeaway for me on this study, first and foremost, it is significantly and statistically significantly demonstrated that they achieved or demonstrated more than double the survival in those patients requiring intervention. So odds ratio 2.37, that if you were delivered in less than an hour, you'd survive. This is the patient we're interested in, right? These are the folks that need intervention. There was also a trend towards favoring the less than 1 hour delivery across the board, but many just didn't reach statistical significance. So that's really my takeaway on this study. If there ever was a randomized prospective odd even golden hour study, I think it's this one. This is a DoD study, and it's really pretty remarkable. New Secretary of Defense Robert Gates steps in 2009. He's a layperson, but he's heard of the golden hour and kind of asks his medical personnel and leaders, why are we not delivering our critically injured folks to definitive care within the golden hour? The average was, less than 2 hours. That was kind of the goal. He changed this almost immediately, pushed the number of battlefield hospitals and Black Hawk helicopters to near double, and achieved sort of his golden hour goal. But with that, he studied the before and after. So hence you have this sort of, although a retrospective analysis, you have this sort of prospective view with a change in the middle. So after the mandate, there was a decrease in median, and let's remember that this is the same war, the same casualties, nothing else changed except this delivered to definitive care, which dropped from 90 minutes to 43 minutes overall. After the mandate, the percentage killed in action went from 16% to 9.9%, P less than 0.001. Missions achieving transport in less than 60 minutes was 25% before, 75% after the mandate. And this was had its largest effect in those critically injured receiving blood transfusions, 7% mortality after the mandate, and 50% before. So an impressive study, great, kudos for having the wherewithal to study the before and after here. Here's some data that'll be on the recording that I'm not going to study in the interest of time. We want to leave plenty of time for questions moving towards the end of this presentation. But for your review, this is readily available. Here, I love these studies. I'm just going to say out loud, there's a handful or more of these studies in good form that demonstrate the difference between outcomes when we compare private transport, individual private transported trauma patients to trauma centers, versus EMS transport. So here's maybe my favorite one first. This one affectionately referred to as the HOMI transport study. This was a USC study done in the late 90s that compared those delivered privately to those delivered by EMS. And this was brought to bear because they would get, like we've all seen, but they had an inordinate number of their trauma patients delivered to the back door of the ED with, lots of horns and then cars speeding away. So they decided to study that because these folks seemed to do well. The adjusted mortality of these patients with ISS greater than 15 was 28% for the EMS delivered group and 18% for the non-EMS delivered group, with a statistically significant p-value of less than 0.001. We in medicine and EMS kind of hate these studies because we like to think we're doing good things for our patients being transported. I don't think this study rebuts what we do in EMS. Why did these outcomes demonstrate improved mortality rates? Simply because of time. This, and there's a handful of others. I'm going to just show you maybe one or two others, but they all demonstrate this, 30 to 50% improved mortality. They also all demonstrate basically cutting the time to delivery for definitive care in half. If you can imagine, these patients are being delivered without sort of the three phases of EMS. There was no need to call 911. There was no waiting for ambulance to arrive. There was no scene time. These patients were simply thrown in the vehicle, delivered to the back door of the ED, and they get a lot of attention with a horn and burning rubber. So there's the first one. Here's another one I want to share. This study looked at 74,000 gunshot wound patients over 182 trauma centers. The majority of these folks were delivered by EMS, 3/4 of them, and about 13% were delivered by private vehicle. Similar outcome here when adjusted for ISS. The EMS transported patients had a twofold increased odds of mortality or dying compared to the private vehicle patients. I don't have it cited here, but there's another similar study out of Philadelphia. Philadelphia allows their law enforcement to deliver penetrating trauma to the EDs directly without calling for EMS. They initiated and delivered a study to us right around 2000 that demonstrated a similar outcome. No one really believed it, so they did it again and achieved and demonstrated again almost identical outcomes in their second publication of that data. So not surprising, nicely demonstrates the importance of the timely delivery of care to definitive intervention. That said, I do want to transition over to part 2 in our course today. We have a crash course on TXA, and would like to thank Dr. Ian Roberts for coming on board and taking the next 10 or 12 slides. So Dr. Roberts, the floor is yours. Thank you for being here.
Thank you, Dave. I presume everybody can hear me. Okay.
We can.
And you're going to change the slides, Dave.
I am, sir.
So if I could have the first. So interesting thing, what they teach you in medical school isn't completely right about coagulation. What they teach is there's the coagulation cascade, and then once everything's over and the body needs to get rid of the clot, there's this process of fibrinolysis to take it away. It's not like that. All the research shows that coagulation starts and fibrinolysis starts immediately. So from the, as soon as a blood vessel is ruptured and starts to bleed, fibrinolysis is there, increasing, the clot is trying to form and fibrinolysis is trying to break it down. Next slide. And the way it works is that there is an enzyme in the blood called plasmin. Plasmin is an enzyme that's like a scissors that chops up the fibrin into little strands. And what happens is there's something in the blood called plasminogen, which is a precursor of plasmin. And then there's something in the blood called tissue plasminogen activator, and they both come together on the surface of fibrin, and they sort of dock to the surface of the blood clot through these lysine binding sites. Now, tranexamic acid is like an anti-TPA because it's got the same shape as lysine, and so it blocks the docking site, and so it can't let this scissors sit on the lysine, sit on the fibrin and chop it all up. So more clot remains and the clot is more stable. Next slide, please. So I used to be a pediatrician and I used to work in trauma care, and you see a lot of children die from exsanguinating trauma, and I was really looking for something that might work. And then I found this drug called tranexamic acid. And there's evidence from surgery, really strong evidence from surgery, that it reduces surgical bleeding. Now, surgical bleeding and traumatic bleeding, sure, there's differences between surgery and trauma, but pathophysiologically, it's the same sort of mechanism of bleeding. And so we thought we launched this big randomized trial called CRASH-2 to see if tranexamic acid would reduce death from bleeding and reduce death from trauma. And so we planned a big trial, big global trial, 20,000 patients, 10,000 get tranexamic acid, 10,000 get placebo. We had 274 hospitals from 40 countries. We didn't have the USA, unfortunately. We tried to. There were lots of USA sites who wanted to join, but a number of things. One is we couldn't afford the insurance, and so they didn't join. I wish they had. In retrospect, it would have saved an awful lot of bother to buy the more expensive insurance. But anyway, that's another story. Next slide. So Dave's already shown this. Most of the patients, well, a good chunk of the patients died really soon after injury on the first day. Next slide. Now, this is tranexamic acid. It's a drug that stops blood clots being broken down. And so the big fear of everybody in this area is that, okay, you're going to cause thromboembolic events. You're going to cause unwanted clotting, heart attacks, strokes, DVT, pulmonary embolism. These are the results. Tranexamic acid, any thromboembolic event, 1.4%, placebo 2.1. Actually, in the CRASH-2 trial, we got a statistically significant reduction in thrombotic events with tranexamic acid. I don't believe, when more data accumulates, it doesn't seem to be that it's beneficial. That might have been a flash in the pan, but there's absolutely no evidence that it's harmful. There's over 125,000 patients in randomized trials now of tranexamic acid in bleeding, and there's no evidence whatsoever of any increased risk of thromboembolic event. So you're not going to make your patient have an unwanted thrombosis. Next slide. So these were, this is the bottom line. This is the most important result. So these are bleeding deaths. There were 198 in the tranexamic acid group. There were 286 in the placebo group. So that's 5.3% versus 7.7%. If you can get tranexamic acid into the patient in the golden hour, you reduce their risk of bleeding to death by about a third. And it's not a fluke, it's highly statistically significant, and it's a double-blind randomized controlled trial with, it's big, it's double-blind, it's properly randomized. So I think this is telling us something really important. If you give the treatment a bit later, it's still effective. If you give it between 1 and 3 hours, you get a 20% reduction in the risk of bleeding to death, also statistically significant. After 3 hours, there's not much going on though. Next slide. So since we did the CRASH 2 trial, there have been other big trials of tranexamic acid in trauma. So after the CRASH 2 trial, people said to us, well, what about isolated traumatic brain injury? And we said, well, it should work there. Why wouldn't it? And she said, well, you haven't proven it. So CRASH 2 trial was a polytrauma trial. So we did another trial, the CRASH 3 trial, 12,500 patients with isolated traumatic brain injury. And the results were essentially the same. So we kind of filled in the missing subgroup of the CRASH 2 trial, those patients with isolated traumatic brain injury. And then more recently, there was the STAMP trial, which the results of which are completely consistent with the CRASH 2 and the CRASH 3 trials. The confidence intervals are wider because CRASH 2 and CRASH 3, there are tens of thousands of patients. The STAMP trial had about 900 patients, but the result is essentially the same. And so, in a way, you could say the STAMP trial was those missing US centers from the CRASH 2 trial. And when you add them in, the result is essentially the same. And similarly, there's absolutely no evidence of any increased risk of thromboembolic events. Next slide. And people have criticized the trial because it was done, it was a global trial. It was done in 40 countries, but not the US. But when you stratify the results by continent, the result, the treatment effects are, entirely consistent. So there's no what's called heterogeneity here. All these continent-specific results are basically just, completely compatible with the overall result. So there's no evidence that the treatment's more or less effective in rich or poor countries, but you wouldn't expect it to be, because we're all human and we all bleed, and the physiology of bleeding does not depend on where in the world we're bleeding. Next slide. And the more we've learned, because when we've got, to start with, we could look at it less than an hour, more than an hour. Because we've got big data now, we can look at it, how the treatment effect varies by time from injury. And there's a 10% reduction in effectiveness for every 15-minute treatment delay. So getting it in the golden hour is essential, but the golden half hour is better, and the golden 15 minute, it needs to be as soon as possible, because it works by preventing exsanguinating hemorrhage. And obviously the best time to give a life-saving drug is one, while the patient's still alive. And Dave's already shown us that patients die really quickly after trauma. So give it while the patient's still alive, and it's more effective the sooner you give it. So next slide. Now, I think this is an important result, because what we've seen in both Britain and in the US and in Europe is that tranexamic acid is being offered, but to only the most severely injured patients. And so you'll get a young man maybe run over by a train, both legs, amputated, exsanguinating hemorrhage. This patient might have a very high risk of death, and tranexamic acid, early tranexamic acid administration reduces that risk. Those patients are being treated. What the patients who are not being treated is the older adult, repairing, cleaning out the gutters, falls from a couple of meters. The older woman falls downstairs, falls out of the bath. they have a lower risk of death, but tranexamic acid reduces that as well. And there are a lot more of them. So what we're trying to urge people is to do two things. One, treat your patients as soon as possible. And two, treat a much wider range of patients. This is not a dangerous drug. My wife's Japanese, and in Japan, it's sold over the counter as a skin whitening remedy. So my wife's friends back in Japan, they would swallow a gram of tranexamic acid every day just to keep their skin pale. Why they do that, goodness only knows, but it's not a dangerous drug. And so we can get more benefit by treating early and treating a wider range of patients. I think that's the last one, Dave.
Thank you, sir. Really appreciate that. Very elucidative. And Dr. Roberts is going to hang in there with us. We're going to make our way towards the end of this for some Q&A. I have a couple more slides to cover in a case report. I want to address one piece here, and this comes up frequently. We've seen it in a couple of studies suggesting, and I want to raise this question for Dr. Roberts because I know he's heard this many times, but should we be getting thromboelastograms before we administer TXA, or should we wait till we get to the hospital before we administer TXA? And I like to look at poor Jack here, who, Rose wasn't going to let him on the raft, but then the nurse, unfortunately, is going to make him wait for the latex allergy test before she'll let him on the rubber raft as well. So, poor guy's just going to die. That's all I can say. But your perspective, Dr. Roberts, on tags, what are you seeing? And I know you've looked into details on.
I feel absolutely not. They're not particularly sensitive. I mean, why should they be? Why should a sample of blood from from a vein in your arm tell you anything about the extent of fibrinolysis in a blood vessel in your ruptured spleen? So they're not sensitive for hyperfibrinolysis. So if you've got hyperfibrinolysis on a TEG, you're very high risk. But there's no need to diagnose fibrinolysis. So they're not sensitive, they waste time. And tranexamic acid, that's why I'm excited to be here talking to you people, is it's a pre-hospital drug. The people who need to give it are paramedics at the scene. And I think, it's not about thromboelastograms. I really don't think so.
Thank you, sir. A couple more quick studies to comment on just regarding TXA. The MATTER study came out right around the same time as CRASH 2, I think 2012. It also corroborated similar data for us. These were the first two big studies that people like to look at. Within the MATTERs, again, these are military and DoD-based injury, and there was some concern that these were a different group of injured patients. But to Dr. Roberts' point, these folks are bleeding. They got TXA. The TXA group had a lower unadjusted mortality, 17.4% versus 24%, p-value reaching significance. Also, they did better in spite of having a statistically significantly higher ISS score. And this was seen to an even greater degree in those requiring massive transfusion. So MATTERS sort of corroborates with respect to data. Dr. Roberts mentioned the STAMP trial. This is a great trial. I've got just a couple of quick points to make here. They did corroborate the data that we saw in CRASH 2. But again, kind of like the golden hour study I pointed out, the takeaway here was, if you just read the conclusion that mortality at 30 days was 8% in patients receiving TXA compared with 10%, didn't reach statistical significance. They had a 2-hour time window limit as opposed to CRASH, which had a kind of looked at the 3-hour time window, really 6 hours, but Ian boiled it down to 3 hours. So the hazard ratio here was identical to that which was seen in CRASH 2, but it did not reach statistical significance. I think more importantly in this trial is the next couple of data points. And I'm sorry, this is a busy slide, but I'm just going to point out a couple of the takeaways for me. And I'll start with the most important, and that's us. So the EMS population and delivery system needs to deliver this drug in less than 1 hour. In this study, if TXA was delivered in less than 1 hour, you ended up with a relative risk reduction for mortality of 40% across the board. All folks that got the drug in less than 2 hours or in less than 1 hour reduced mortality by 40%. And that was obviously statistically significant. The other two data points that we can take away, which are quite interesting, no surprise, but again, the most injured benefited the most. So even at the 2 hour interval, if you had a systolic blood pressure less than 70 and you received TXA in this trial, you had almost half the mortality of the comparative group, the placebo group, and that reached, was highly statistically significant with a p-value of 0.003. The last point to make here, which is really interesting and just really confirms a dose response. They had 3 different doses in the STAMP trial, and it corroborates what we would think intuitively. They tried an abbreviated drug administration scheme where they just gave the 1 gram bolus, didn't reach statistical significance. They matched the CRASH 2 approach, 1 gram bolus followed by 1 gram over 8 hours. Didn't quite reach statistical significance overall. But interestingly, they tried a higher dose regimen where they gave a 1 gram bolus followed by another 1 gram bolus. So a 2 gram bolus of TXA followed by the 8 hour infusion. And that did reach quite marked statistical significance with a risk reduction for mortality pushing 27%. And confidence intervals on the right side of the vertical and a statistically significant p-value. So some important takeaways in STAMP. TXA in peds, we don't have time to get into, but this is interesting. The first sort of pediatric reporting came through the same Battlefield hospital that published the MATTER study and had similar results. This same Battlefield hospital would take on pediatric patients, treat them, and they were quite markedly ill. 766 pediatric patients less than 18, average age of 11. The takeaway here is that about 9% of these folks received TXA. Like MATTERS, the group that got TXA had higher ISS scores, worse hypotension, acidosis, etc. But the TXA group had markedly and significantly reduced mortality, approaching 30%. So no surprise there. I'm going to share a case report. We're going to hurry through that so we have plenty of time for Q&A. This is a case I was involved with in my CalSTAR years. This was the first patient, the first pediatric patient that we gave TXA to in the field. This 9-year-old female, 30 kilos, was the restrained front passenger in an off-road vehicle. She was sitting right here when this Hummer came over the top of a sand dune and kind of impaled her right there. She was literally sort of crushed under this thing. Her initial GCS-5, unresponsible. Sorry, the Hummer was unresponsible. She was unresponsive with minimal respiratory effort. Dad, as a side note, interestingly, I ended up knowing Dad, who was a firefighter paramedic in Sacramento. He gave his daughter rescue breaths while 911 was called. She had, I think fantastic treatment overall, and I'll talk about that briefly. But her initial assessment demonstrated, significant lacerations, blood in the mouth and nose, neck okay, chest. She had a full thickness lac to the right shoulder, coming down towards the right nipple with significant bleeding. Right clavicle with crepitance. Her GCS was 5, no real responsiveness. Abdomen seemed okay initially. Extremities, open right tib fib fracture, multiple exposed bone segments, no distal pulse Initially, that was repositioned and pulses were reobtained. So treatment en route, they called air ambulance to the scene, who transported the patient directly to the local level 3. Initial vitals concerning, O2 sats 95. She gets a bolus, her legs repositioned. She's transported to the local hospital for airway management stabilization and other interventions. This gal had great treatment by the flight team. I'll make side note here that pediatric patient intubated at the receiving hospital by the flight team, appropriately utilizing our RSI regimen as we see in our unified scope currently. She received also propofol, had a blood gas, got some more LLR, got some blood, got TXA within the first 45 minutes, got a gram over 10 minutes. The flight nurse was acting perhaps just outside of our policy, but I'm glad he did. Other findings included, really impressive brain injury, closed fractures clavicle, open fractures tib fib, lung contusion, pneumo, hemo. Her ISS, as I calculated, it was greater than 40. She ends up being transferred from this community hospital over to CRMC in Fresno, level 1 trauma center. It's more blood, more FFP. Ends up doing quite well. There are many spokes in this wheel. She got all kinds of great trauma care. She got good pre-hospital care. I see TXA as one of the spokes in this very large wheel that kept this little gal rolling along. But she did much more remarkably than we would have expected. Not enjoying her rehab here. A couple months out, doing extremely well. And finally, back to Dad. And I checked in with Dad to be sure I could share these pictures yesterday. He said absolutely. He also shared with me that she's playing guitar. She's quite an artist and getting straight A's in school. So we're very pleased with this outcome. So off to Q&A.
Thank you both very much for the outstanding presentations. I have 3 takeaways from Professor Roberts I picked up on. One is TXA is a pre-hospital drug. 2 is we should give it as soon as possible. Just because it works up to an hour or more doesn't mean we should wait. It's going to work better the sooner it's used. And 3 is we should be treating a wider group of patients, for example, geriatric patients with more minor trauma. So with that, I will open it up to questions. Feel free to put your questions into the chat or raise your hand. I see a question in the chat from Roxanne. Does it interfere with the PFA test, which would be a screening test for platelet dysfunction? Professor Roberts, do you want to take that one?
Yeah, I don't think it does, but it's not top class. It's not a top class answer. I've got no reason to think it does. I sort of really keep on top of the TXA literature, and I've never read that. But so it's a good one. I don't think it does, but I will. I'll make doubly sure at some other time.
Thank you, Dr. Duncan. Anything to add to that answer?
No, thank you. Thank you, Dr. Orr.
All right. Any other questions? I don't see any hands up. I don't see anything in the chat. So I'll ask a question. What about uses for other types of conditions like epistaxis, vaginal bleeding, things that aren't necessarily traumatic in nature?
Can I just ask, given we have a little bit of time and maybe not as many questions as we were wondering, can we ask Dr. R to spend a couple of minutes on the woman trial and maybe specifically, postpartum hemorrhage, given your question?
Yeah, and we do have at least one other question, so keep that in mind. Thank you.
So we did a big trial. It's called the Woman Trial. We randomized 20,000 women with postpartum hemorrhage, and we got exactly the same result as we got in the CRASH 2 trial, but in postpartum hemorrhage. So if same time dependency, And if you give it early, it reduces death due to bleeding by about a third. And so now we're working with the health organization to upscale the availability of tranexamic acid all around the world. We're also doing another trial called the Woman 2 trial. We've randomized 10,000 patients already. And that's tranexamic acid for the prevention of postpartum hemorrhage. So the answer is yes. It's surgical, traumatic, and postpartum hemorrhage. The only one that we didn't find clear evidence of benefit, we didn't find any evidence of either benefit or harm, was gastrointestinal bleeding. It seems like you've got to have some sort of tearing of flesh, either from surgery, trauma, and postpartum hemorrhage all have that sort of blood vessels are ruptured or torn. But in this most of the patients in our big gastrointestinal bleeding trial, they had esophageal varices. And maybe it's a different mechanism of bleeding. It's a pressure thing. They're under pressure, these varices in the esophagus, and they quietly pop, and then they glug, glug, glug into the stomach. So you don't really know when the bleeding starts. And so we didn't see the same benefit. But surgery, there was a big trial in the New England Medical Journal a couple of months ago called the POISE 3 trial. Tranexamic acid in non-elective surgery, 10,000 patients, near enough. Tranexamic acid, 25% reduction in major bleeding, same reduction in the need for transfusion, no increase in adverse events. So it really does work, tranexamic acid.
Excellent, thank you. And Dr. Sloan, go ahead with your question.
Thanks very much for this is a wonderful presentation. I'll admit I drink the Kool-Aid. One of the things that I am is medical director for Mercier, and our company is set up to do this, and in fact does this in other portions of the state. I had brought this up with our local trauma surgeons a couple of years ago now, and they were quite skeptical to the point where I was discouraged from encouraging the use of this. And so is this something that we're going to bring up with MAC to try and get our trauma surgeons on board so that we can, have a proper functioning system?
Sounds like that question's for me. MAC is our medical audit committee, which is the group of trauma surgeons that meet regularly and advise us on our EMS protocols for trauma. And we did invite them to this meeting. I think there's a couple of trauma program managers here. I don't see any of the physicians. I did see one earlier, but he's probably doing surgery or something like that. So certainly, Kristen, we will revisit that. And that was one of the ideas of this lecture, was to get the dialogue going again from the people with the most expertise in this space. Does that answer your question?
Wonderful. And thanks again to both Dr. Roberts and Dr. Duncan.
Christian, if I could say something, I think being skeptical is good. So we can't blame them for being skeptical. And a lot of people were very skeptical because the whole trauma community were burned by their experience with activated factor 7A, Novo 7. So it's heavily marketed by Novo Nordisk. It was originally developed as for hemophiliacs, and they thought, well, let's expand the market. Shameful promotion practices. People started using it, and it did cause vascular occlusive events. It was a powerful pro-thrombotic drug. So they got burnt with these patients having thrombosis after this drug, and so they were very skeptical. But now we've got lots and lots of evidence. And so the evidence should overcome our skepticism. The Army are completely behind tranexamic acid. It's in all combat medical care protocols. I even had a message from President Obama's physician to say that they were using it. It was part of the kit that they would use on the president if the president was injured or shot. And unfortunately, quite a lot of them do get shot. But so I think it's a good time to revisit the conversation with trauma surgeons, because things have changed now. I think that I was at a conference called Thor, a couple of lots of trauma surgeons from the United States, and there was quite widespread acceptance that, you know, this is an appropriate, this is, you know, should be used as soon as possible.
It's interesting because I remember reading about TXA a long time ago, maybe around 1990 or so. And it's like, wow, this is pretty convincing. This looks very promising. And some people said, you know, the problem is it's too cheap. Nobody's going to use it because, you know, it's not being marketed by some company. So
You're so right. I think that is the problem. If this was a patented drug, you'd have all been to some nice conference with a fluffy towel and you know, and yeah, and you'd be smoothed about how effective the fact that it's an inexpensive generic drug should be an advantage, but in fact it's a disadvantage.
Exactly. And Dr. Khan has a question. Go ahead.
Well, mine's really easy because it was basically the same question as Dr. Sloan. You know, given the overpowering evidence that we've seen here and the fact that we've had 10 years to refute it and haven't, I was hoping that we would be looking at actions to move forward with implementing this in our system, which obviously does involve you know, collaborative conversation with our trauma surgeons. So, you know, basically the same question, but thanks for calling on me.
Thank you. Is there anybody from the trauma community who would like to speak to any concerns about it being used in the pre-hospital setting? We're a friendly group. You can speak up.
This is Matt Durker-Corian at Rady Children's, the trauma program manager. I agree. I don't see any of the TMDs on the line, but I do recall the same kind of hesitancy the last time it was discussed. And obviously, you know, pediatrics were sort of a little bit separate there, but having worked in the pre-hospital realm, you know, I can attest to having seen this work in other areas of the country pretty successfully without really, you know, again, from an anecdotal standpoint, without really issues of patients that I would bring to trauma centers. So I'd be really curious to see if anything has changed in the eyes of the TMDs and TPMs here.
Thank you, Matt. Anybody else like to speak to that? Are there any other questions? I don't see anything in the chat and I'm not seeing any hands raised, but please help me if I miss somebody.
Yeah, Dr. K, I think Dr. Niki's on from San Bernardino County, and he headed up the CalPAT study. I'm wondering if he could just give a 1 or 2 minute vignette of where they are. They initiated TXA for trauma in both San Bernardino and Riverside and had similar outcomes. The numbers weren't really prominent upon that publication, but Dr. Niki, are you available to share any additional?
Yes, thank you so much, Dr. Duncan and Dr. Roberts. Wonderful. In fact, we used Dr. Roberts' platform after we read the Crash 2 in, you know, latter part of 2012. We tried to get everybody lined up. So for us, it was pretty much what we did was a coalition for pre-hospital while we were doing the hospital also administration. And that showed a similar finding as Crash 2. The biggest pool that I've had, the best information that we got was it's cheap. It doesn't have a side effect that we have noted. And it seems to improve survivability of the patients. And we are continuing as of, you know, when we presented to MDAC at time, they all approved that this should be a part of the local scope of practice. So we have been using TXA in the setting.
I want to segue on that and just add that TXA is transitioning into standard scope for paramedics. Dr. K, I just double checked on that. I had helped initiate that in my EMSA position. Dr. Garzon continued and confirmed that that and several other drugs are going to be transitioning into standard scope rather than local optional scope for paramedics in California. So that's coming.
Yeah, if I may add, many publication came along from surgical standpoint, critical to TXA. When you look at those details, they're really beating the group to selective critical patients that they have had in the hospital for a while. And it's not really the true function of TXA as Dr. Roberts and his colleagues were designing and presenting at the beginning. So when you look at the true result of them, they are not really, they're not reproducible in our patient population. We don't have that kind of side effects. I'm not sure what they're doing with their patient when they have PEs and DVDs on that rate, significant rate that they have presented in the past. So we are still continue to use it in San Bernardino and Riverside County area, and we are very pleased with it. And we are grateful for Dr. Roberts and his team to put that on a map. It's amazing, and I agree with everybody that mentioned down there because it's a generic, cheap drug. It doesn't have any push from the drug companies into our market in US.
Thank you so much, Dr. Nikki.
Thank you very much, Dr. Nikki. We appreciate you joining us. And in the chat, Katie Goss says that she's the trauma program manager at Scripps Mercy, and on the East Coast where she was working before TXA was given pre-hospital there. Any other comments or questions before I give our speakers an opportunity to make some final remarks? Great, Dave, over to you.
Thanks, Dr. K. Lastly, I mean, the one-liner for me is going back to some of the high points that we've made in this talk. Number one, the evidence is irrefutable. I think the best evidence that we have demonstrates we need to be giving this pre-hospital. This is a pre-hospital drug. This is a before 1 hour drug, which puts it squarely in our pockets. If we don't give it in that first hour, it unfortunately ends up being markedly delayed. The hospitals have lots of other things to do. So I'll hand it over to Dr. Roberts for a final comment. And thanks everybody for your attention. Really appreciate it.
Well, thank you, Dave. Just one technical thing and one sort of strategic thing. So technically, the recent work we've done is we've tried to, we've found that intramuscular tranexamic acid is really well tolerated and rapidly absorbed. So we did studies thinking of places where they couldn't give an intravenous dose. And I thought, well, if you can't give an intravenous dose, intramuscular might be the next best thing. But actually, it's so rapidly absorbed from muscle, even in shocked patients, that it's almost it's almost the first just as effective as intravenous, because the time certainly the time it takes me to cannulate somebody, you'd have got therapeutic levels with an intramuscular dose. So we've got new data on that, and it's very useful for example, for trapped patients. You can only see a little corner of the patient trapped inside a vehicle. If you can see a deltoid or a buttock or a thigh, you can give an intramuscular dose of tranexamic acid. The other thing is a kind of strategic thing. I thought it was about evidence implementation, but I've realized over the years it's all about emotion and relationships. And so if you want to, there's saving lives in a dramatic way, but actually if you make friends with a trauma surgeon and just be interested in them, talk about their family, it's about emotion, it's about making friends. And so I've done so much data head-oning and it didn't get me anywhere. And now, and if we're really interested in the patients, we've got to have these sort of open, honest arguments and just see each other see each other's shared humanity. And I think that's the way forward. But that's only my own personal view.
Brilliant, absolutely brilliant. And just in case you don't know, I spent 15 months as an A&E consultant at St. George's in South London.
Guys, just round the corner here. I live in Wimbledon.
Oh, wonderful. All right, well, thank you everybody for joining. And again, a huge thanks to our speakers, and we are ready to move forward and see what we can do with TXA in San Diego County. So thank you very much, everybody.